So our speaker today, thank you so much for joining us from the East Coast. Rachel Zimmer is an assistant professor in gerontology at Wake Forest. She's also the director of their mobile health program. She's a doctor of nursing practice and a gerontologic nurse practitioner who's clinically active and also has research expertise in social determinants of health, particularly in food insecurity, and has done a lot of research and also advocacy in this area. And that's why I invited her to come speak, because the work she's doing is really important and something I think we don't think about enough in primary care. So thank you so much for joining us. And I'm excited to hear your talk.
Thank you, Kate. All right, so it's great to meet you all, and I will go ahead and get started since I know everybody's on a tight time limit. Rachel Zimmer, nice to meet you all. I am going to talk a little bit about our food prescription program, but I'm also going to talk a little bit about food insecurity as well, and we'll start there. So I live in North Carolina. When you look at the prevalence of food insecurity, and this is from 2021, if you look at it nationally, about 10% of US households say that they have food insecurity. And in North Carolina, we're a little bit above the national average at 12%. But when you break it down by race or ethnicity, you'll see that Black and Hispanic populations are almost double the rate of food insecurity. So I don't know if I have it in this slide, but food insecurity goes along racial lines and is specifically tied to racism. What you'll see is food insecurity rates are much higher in communities that are disenfranchised. And what you're seeing here are just those differences, and they've always been relatively consistent since we've been measuring food insecurity. When you look at older adults and you're looking by race, what you see here are the rates of a Black versus white food insecurity, also with the AAPI population integrated there as well. And when you look at the second table, you're seeing the very low food security. And what that means is this population's, when you say someone has very low food security, that means they're hungry. So there's different levels of food security. So this would be that they're actually hungry. And then if you look at our Hispanic or Latinx population, we also see much higher rates of food insecurity. So I think it's just good to see that visually, because I think older adults, sometimes we don't think about the fact that they do struggle with food insecurity as well. And I always like to just kind of point out that food insecurity impacts people across the lifespan. For children, it's hard for them to learn in school. There's much there's a lot of developmental delays that happen. And what is not included for older adults is food insecurity. More and more evidence is showing that it's tied to depression. So in addition to the other chronic diseases. So one of the issues that you'll hear sometimes, especially when insurance companies are thinking about, or we're advocating for insurance companies to help pay for food, is, well, does it really increase healthcare costs? And so one of my friends, Dr. Deepak Palak-Shapa, has done a couple of studies at our institution and just published one actually here, where they're able to isolate that food insecurity did actually cause greater healthcare expenditures in the United States. And so here's just one of the tables that they use to show those differences. So, we're really trying to isolate and show that food insecurity, even by itself, increases healthcare costs. Well, it can be really challenging to address food insecurity. Our systems don't make it easy. And one thing that I do is I work closely with the Food Research and Action Council and the AARP Foundation. This survey report is actually we're still doing edits on it. It hasn't been released yet, but I thought it might be helpful for you to kind of see where the conversation is heading in this space. We did a national survey of healthcare providers who provide primary care and home-based primary care and other types of care to older adults. So we were interested in their beliefs, their practices, and what are they currently doing to address food insecurity for older adults in their clinics. And so it was interesting because almost like 95% of providers who answered the survey said, yeah, we believe that addressing food insecurity is really important. And I thought that was really interesting. And they also, a majority of them also said that they did address food insecurity, which I thought was really interesting too. And so we narrowed down a little bit more. We're like, okay, if you do intervene, what are you doing? And so what we saw here were sort of the main ways that people were saying that they were addressing food insecurity. So you see referring to a social worker. And I don't know about you, but I know in the geriatric clinic, we don't have a social worker. Other clinics do, but our particular one doesn't. Help patients apply for SNAP. So, you know, I don't know that the provider necessarily does that in many cases. I think what they're talking about are the teams, providing a paper with information, providing verbal information. So there are some areas for growth and opportunities for helping providers, you know, with referring, maybe the most effective ways. And there's a lot of gaps in literature as well. So, I don't want to necessarily, this is sort of an emerging conversation. So, I know how many things we have to address during a clinic visit or a home-based primary care visit. So I just want to kind of point out that, you know, there are some areas for improvement when it comes to food insecurity and addressing it. And, you know, we also asked, you know, what supports are needed, if you want to better address food insecurity, what do you feel like you need? And finances was brought up, staffing was brought up, training was brought up, and then also support on closed loop referrals. So in many cases, you know, if you give a patient a piece of paper or verbally tell them about resources, how do you know that they reached out to those resources and that resource is actually now something that is sustaining their needs? And so those are the sorts of things that I think many providers were saying that they needed. There's some research out on evidence. So Dr. Amelia DeMarcus, she's a family medicine physician and a researcher out of UCSF. She was one of my mentors a few years ago around food insecurity, and she did a systematic review looking at different studies and, you know, evidence around different programs and how they were impacting food insecurity. And really she showed from the evidence that existed at the time that home delivered meals seemed to be the most effective. And that research was Seth Berkowitz's research. And if you're in the world of food insecurity, Seth Berkowitz is sort of like the god of food insecurity research. So he's out of Chapel Hill and has done a lot of work looking at diabetes outcomes and also healthcare costs associated with home delivered meals. Also, the evidence does have some mixed data on vouchers. Uptake and transportation tend to be a lot of the barriers for vouchers, but there's some mixed research. So it looks like it could potentially help, but definitely active over passive referrals. So active referral programs appear to be more impactful than giving a piece of paper to somebody in the clinic, for example. Some of us say, you know what, we want to take it a step further and do something in terms of, you know, starting a program or trying to partner with community CBOs and such. And so I do community-based participatory research. I started a mobile health program here at the hospital. And so I'm in the community a lot. And so I've gotten to know a lot of nonprofits, and I was chair of the Piedmont Triad Regional Food Council for a little while. And we really got to know a lot of the different sectors that try to address food insecurity, but also the local farmers, urban farmers, the food bank. And so there's this growing partnership between our healthcare teams and these CBOs and nonprofits in the community. And you really have to have that if you want to sort of collaboratively address food insecurity. So, I have found that as well. So in 2020, and there's no way I can go into like the full breadth of what we did, but I started a food prescription program because when the pandemic hit, we were actually in the middle of doing focus groups to help a nonprofit start a market in one of the underserved communities that we work in. But of course, our focus groups were in January and February 2020, March hit, and there you go. So we actually had some seed funding, and I say we, myself, and then Dr. Kimberly Montes, who is a friend of mine, but she's a pediatrician. So we put our funding together and we were able to sort of start a program where we would pay farmers to put produce in boxes and also get meals, prepackaged meals that were nutritionist informed, to our families that were food insecure, to the older adults who were homebound and now lacked access to food because nobody was able to come into their homes and they were scared to death of going out of their homes. And so we were able to actually, and I always say, I don't know how I got the funding to keep it going, but we kept that going for 1.5 years. And then I was able to do some research as a part of the program. So we published a couple of papers. This one is more on the, strategies and lessons learned from starting a home delivery program. So I talk more about the aspects of how we developed it and how we operationalized it, and then some of the pilot data that we had. We did show that we were able to decrease food insecurity, and I forgot to tell you, so we served 150 people every week with produce boxes and meals. This was not a research study, this is an intervention, and then we were like, okay, maybe we can get some of the participants to participate in some surveys along the way. So we did not say that they had to participate in the surveys to be in the program. We felt that was unethical. So what you're seeing here is really just about 30 people from the group consistently answered surveys. So we started with 88 people willing to answer, and then it kind of dwindled as time went on, but it was enough to at least give us some pilot data and kind of see where the needle was moving. I will say we did these surveys every 3 months, and it was at the 6-month survey that we really started seeing some change. So you can see that very low food security, and remember that's the worst of the food security measure, decreased significantly in our pool of the patients that did the surveys. I'm more of a qualitative researcher, so I was able to actually also do some interviews of the participants. And so we also published our paper on exploring the perceptions of the participants that were in our program, and our themes, and none of this is terribly surprising, but people felt motivated to eat and prepare healthier foods. They felt like their well-being was improved. They had, more healthy dietary habits. They actually felt that their social isolation was lifted because they had consistent contact with the delivery drivers. And also we had a social worker who was the coordinator for our program. And so she was always checking in on the participants. And then of course we removed the logistical barriers to food access, but also people were saying that they had better financial well-being overall. So they were saving money on their food so they could use their money toward other things that were important to them. And then also we had several suggestions for improvement along the way, which we integrated. So take 2. So I stopped that program in October 2021. I said I was never going to do it again because it was basically like starting a business. And keep in mind, I run the mobile health program. I also do home-based primary care, and I'm in administration. And I thought, oh my goodness, what am I doing? But then there's a company in North Carolina. It's called the Produce Box Company. They approached me. I was actually ordering produce from them just because I was curious, like which farmers did they buy from? How good is their produce? And could they potentially be a partner in the future? But I wasn't necessarily seeking them out to be an immediate partner. But they saw that I worked at Atrium, and they asked if I knew anybody who worked in food insecurity, and I said no. But after the initial reaction, I said, yeah, why are you asking? And so they were really interested in becoming SNAP vendors, and have done some work with Duke and Chapel Hill with some food prescriptions. And so they were interested in maybe trying that in our area. So we partnered with them in the YMCA and Second Harvest Food Bank to go ahead and put in another application for a grant. And so we were able to get USDA funding to actually do a research study this time. So this time around, it is a research study. We just finished enrollment at the end of May. So we have basically The program sort of builds off of the learnings of the first time around. So we're doing produce box delivery. The participants get 3 different choices of the box every week as to like what they want per like a mix of vegetables. We do have a protein source in one of the boxes. That was feedback from the first time around. And we're enrolling 125 participants to receive the produce box. And then also it's an integrative health coaching model. And then also, and I didn't mention this the first time around, I measured depression and loneliness in the first cohort because I had mentioned this at the beginning, depression and food insecurity are correlated. And we actually found that depression and loneliness did not change. It didn't get worse and it didn't get better during the pandemic. It was stable. And I thought that was really impactful actually, because for the small group of people who did the surveys, that meant that they were not suffering as much as we were hearing, you know, other patients who weren't getting the intervention. And of course, I couldn't prove that, but it was just something that I noticed. So this time around, we are measuring depression and loneliness again. About 30% of our patients have depression, and moderate depression. Their PHQ-9 is over 10. We were just looking at the baseline data. For anyone who screens positive for depression or loneliness, or anyone who's an older adult, they get what are called wellness checks. So pardon me for saying this, but I do believe medical students could benefit from empathy training in some ways. And so what we've done is we've partnered with a medical school to actually do sort of twice monthly phone calls with one of the older adults for 6 months. And so then they would do a warm handoff to another medical student who would then finish out that relationship with that participant. And then also we have nutrition coaching, education, and even some peer support. We just did an event on Tuesday where we had cooking stations and made salad dressing and, you know, just did a bunch of fun stuff with the participants so that they could share recipes with each other, talk about strategies together. And it was a lot of fun, actually. So this is a really busy slide, but essentially you're looking at the measures that I'm looking at over the next year. And our primary outcomes are food insecurity, fruit and vegetable intake, healthcare utilization and cost. We are a part of a larger national cohort. So we all actually have some of the measures are the same. So it's actually kind of a beautiful thing because then we have this collective data pool showing impacts across the country. And the report, year 3 report just came out through GusNUP and showed some pretty great findings actually. For example, for every $2 million spent in produce prescription or nutrition incentive programs, it generated $8 million of local economy. So, I mean, it's a win-win for the economy for sure. So anyways, I do community informed work. And so you see that we have a community advisory council as well who helps us along the way. Yeah, so I figured that was all I was going to be able to fit in. One thing I didn't make reference to is we do have a matched cohort. So for the participants that are in the program, we also have a group of participants who are not in the program, not receiving the intervention, and we're measuring the same measures. They're actually doing surveys as well. And I just applied for funding to roll them into the intervention. Hopefully I'll get it after a year. So that way they will be able to, I'll be able to get some pre-post data, but also some matched data as well. So I put some resources in here. And then also, oh, the evaluation survey as requested. Hopefully I did that in 20 minutes.
Great, that was fantastic. Yes, you did. And it was really great. The work you're doing is so important. And this is such an important topic. We have some time for questions if you're taking some questions. Mm-hmm. So if you have a question, feel free to put it in the chat or to unmute. While people are thinking about their questions, I have a question. I was wondering if you have recommendations for the best way to address food insecurity in our primary care practice to discuss this with our patients.
Yeah, I think some of it is making a case for the problem. So I know that in our institution, we're actually mandating that people have to ask at least once a year about food insecurity, housing insecurity, domestic violence, because we found that less than 1% of the patients are even being asked. So that was pretty significant. Now, whether or not, I know we believe that there's more than 1% of the patients, we just think people are asking in different ways and then charting it in different ways. But like having a consistent way to at least, let's show the problem. The other thing is you can Z code food insecurity. So there's a Z code for food insecurity. And that's another thing too. I know you don't get reimbursed for it right now, but you will later. And so I think that also helps to identify patients who have housing insecurity. There's Z codes for that too. So I think on the provider side, even if you don't feel like you have all the resources in your community, at least capturing it. And then, and I really like community health workers. I just got a grant to work, train a bunch of community health workers in our community. I think if you can think about models that support community health workers, because they're the boots on the ground, they're usually from the communities they serve, integrating them into a model of care and primary care, I think could be really powerful. I don't think providers are the best people to ask these questions to patients. I think I actually think that maybe having the community health worker before or after the visit, have that conversation with the patient because they're peers. And so there's going to be more comfort around answering questions like that versus the hierarchical sort of relationship. Now, I say that, but then, some of us have really good relationships with our patients and we can ask that question. I just think sometimes it can feel a little bit scary or patients won't answer. And there's some research to support that. I know Deepak just published a paper showing that if you verbally ask a patient, they're actually, they're less likely to tell you. So they're more likely to admit it if they write it on paper by themselves. So anyways, I think capturing it could be a good first step. There's a lot of resources already that are out there to train you on how to address food insecurity. I know FRAC has a free module for older adults specifically, and I can share that resource as well.
That would be great. Yeah, we'll send a follow-up email to everyone with some of these resources. Would you be willing to share your slides with everyone too? Great.
Yeah.
So we can share those out.
I might have to pull the ones out from the provider support.
Yes, whatever version you are okay with sharing, we'd be happy to have. So
yeah,
great. Okay. Barb, did you want to unmute and ask your question?
Sure. This was great because there's not a lot of good research that is accessible to people regarding this effort. But so I'm wondering for those who might be interested in launching such research and getting funding for these interventions, how do you plan for the ongoing support when the funding ends? Because it seems like you are really caring a lot about the ethics of all of this, and this is a vulnerable population. So how do you do that?
Yeah, it's funny. I just was at a national meeting, all of us that have the funding, and we had this conversation. And there's different strategies. Now GSNP is a strong funding agency. So they fund every year, they release an RFP. And they will fund ongoing. So usually if you have a year of GSNP under your belt, you can usually get a follow-up year. And I do think it takes a variety of, I think it's a mix. I think there's some grants to get us into the space of proving that these models can work, hopefully. But then also there are the 1115 waivers, that you can, a lot of the waivers, I'm talking about Medicaid, a lot of the Medicaid waivers have focused on mental health. And part of the reason I'm looking at mental health with food insecurity are that they're tied together. And a lot of the states a lot of the programs in some of the other states, we're talking about how they've been actually able to tie food insecurity programs or payments into some of the 1115 waivers. California, they were almost over the finish line and then it didn't pass at the last minute. So, there's sort of this conversation around the MCOs and the value-based care models, and can we integrate some of this work into that? But they want to see, well, does it really decrease healthcare costs? It's a great idea, but food's expensive. That's usually what you hear. And so you just really have to kind of show, that's why research like this is needed to show with some intention that programs like this could be cost effective and be valuable, because the produce boxes cost $25 a box, and then It's like $5 for the delivery. So it's really not that expensive, you know, each week. Hopefully that answers your question. So we all have different ways of going about it, but we don't really have the answer. So.
And before we wrap up this discussion, I was just wondering if any of the folks from the area agencies on aging who are on could comment on how reaching out to the AAAs could help with food insecurity and the best way to do that.
I can go first. I'm Brianne from the Agency on Aging in Southwest Washington, and we have three main ways that we're helping to address food insecurities through our core service area of nutrition. All agencies on aging have to offer some type of services under nutrition. So we offer home delivered meals for homebound seniors, and we saw funding pretty much dramatically increase during COVID, and we were able to serve a lot more people, which was really neat. So it was great seeing your data on that. Like, yes, what we're doing is really actually making a difference. It was cool. So thank you. The other thing we do are congregate meal sites. So that's a place where older adults can go and get a hot meal. It's usually in like, you know, a community center or a Grange Hall, and those are free. People can contribute to those for the cost of the meal, but they can get them for free as well. And then we also do senior farmers market nutrition vouchers. Those are actually just going live today. In our area, people are getting $80 worth of vouchers that they can use all summer to buy fresh fruits and vegetables at farmers markets. Awesome. And I guess to answer the other question about how to access those, if you're in Southwest Washington, you can contact our Aging and Disability Resource Center, and I can throw contact information in the chat.
Thanks, Brianne. I don't know, Fong, if you had anything you wanted to add to that.
Yes, hi. So yes, this is Fong, Primary Care Liaisons for Saddle King County Area Agency on Aging. In addition to what Brianne shared in the King County area, Seattle particularly, we have the Fresh Bucks program as well, and that provide additional vouchers for Seattle residents to buy fresh fruit and vegetable as well. And in local store also. So that's another program that's not part of the AAA, but it's part of the city of Seattle.
Great, thank you, Fong, and thank you, Brianne. Any last questions? Great, well, thank you so much, Rachel. You are welcome to stand for the case presentation, but I also know that you're busy and that it's the end of your work week. So it's up to you either way. But we're going to move on to our case presentation from Dr. Nguyen. Thank you so much for presenting this case.